Welcome to Reflections, a program where we discuss values and virtues for the transformation of the individual and the society in general. I am Father George Ehusani, and I have with me in the studio once again today Professor Felicia Anumah. You're welcome.
Thank you.
Professor Anumah is the Dean of the Faculty of Clinical Sciences, University of Abuja. She is a professor of endocrinology and diabetology. And this segment of our discussion, I would like us to reflect on the clinical disruption in hospitals, something we can call COVID-19 and clinical disruption in our hospitals. What's going on with the normal clinical work of a hospital? Your normal consulting days, and are people coming? What I'm hearing is that people are not coming in good number for their normal consultation. People are afraid of going to hospitals. And yet, there are women who are to deliver, who need to go, even before delivery, who need to go for their clinic days, prenatal. There are others who are scheduled to visit the doctor from time to time. There are people who have some minor ailments who need to go to hospital. I am told that many people are frightened stiff, and anything called hospital, they are afraid to go.
Yes.
I hope we don't end up with a major challenge with people dying at home, unable to go to hospital, not because doctors are not ready to see them, but they are afraid to go and see doctors. What's going on in your own hospital?
Well, thank you very much. Well, COVID-19 was an unexpected problem that came upon the whole world, including Nigeria. Initially, we didn't really understand the gravity until things started unfolding and we saw the seriousness of the whole problem. What we did in my hospital initially, there were meetings. We had meetings with the CMD, you know, how we are going to continue to work, cope, but take some caution. But a stage came when we saw the seriousness. We had to close routine clinics from running. We had to close routine clinics. The reason being that, okay, some patients sometimes don't give you the right information concerning them.
The truth of what they are feeling.
History of travel, they may keep it away from you. And you know, the way our clinic setting is that there is this table. I sit on this side of the table, and the patient sits rightly here. And so I have such close contact with the patient. The patient
and you may even need to touch the patient.
Yes,
and examine
then
the patient.
after that, after you know, interaction, so close, and then I examine the patient before I make up my mind, you know, what to do for this patient, because the contact is so close, very close. Actually, I tell my colleagues that we are privileged in the job of, you know, being a doctor. It's a privileged profession. It is unique, not because our brain is bigger than any other person, but God has considered us a noble instrument to use. Why? Our job is the only job where we have the privilege for a human being to be naked before us. I'm not even talking of physical nakedness.
Both physical and emotional.
What a man will not tell his wife, he will tell the doctor. What a woman will not tell her husband, she will tell the doctor. So we know so much about human beings, and that is a privilege. Now, we are the only ones that also have the privilege to watch a human being take his or her last breath. We watch it. It's a very precious spiritual moment in the life of any human being. But every day we are there to watch this. It is also a privilege. So you also watch a human being come into the world. Yes, we also watch a human being being brought
into the world.
And that baby takes the very first breath in his or her life. We watch all this, and as far as I'm concerned, it is a privilege and we must handle it as such. So a situation where this closeness is so much when we are talking about social distancing, how do you effectively attend to a patient? with social distancing. That is why in some places they have had to consider
Online.
closing routine clinics. And Enugu, for example, they are doing telemedicine. You know, the patients can call them and, you know, give some of their complaints, particularly the old patients who needed to have been coming for their routine clinics, and then they can, you know, tell them, okay, do 1, 2, 3. And as far as, for example, let me use diabetes as an example. Diabetes is a situation, is a condition where the patient needs to do so much for himself. We call it self-care, self-management. So they need to have glucometers, that's the equipment to use to check their blood sugars by themselves. They need to have the one to check the blood pressure by themselves, and then they need to do so much for themselves. So what we do in this situation now is, those of them that have our numbers, they call us. I have this problem, I have this problem, I have this problem, and we say, okay, do 1, 2, 3. It's two ways. The doctor is afraid of contracting COVID-19 from the patient.
And the patient is afraid.
The patient is also
getting it from the doctor.
Afraid of getting it from the hospital setting, particularly in our teaching hospital where they hear that we are treating. In fact, the very first time they brought 6 Chinese people to be tested, to be quarantined in our hospital, even the sick patients in the wards were run. They say COVID-19 has come, COVID-19 has come, and everybody...
They got up from their beds and ran.
That was even before we started admitting the sick ones. They ran. So, so the patient is afraid of getting it. The doctor is also afraid of getting it. So it's a big dilemma.
The one who is admitted for malaria.
Yes.
Now hears that COVID-19 has arrived. He got up from the bed and ran.
Even the ones that didn't think they could walk before, they got up and ran because they heard COVID-19 had come to the hospital. So it's two ways. It's a very difficult situation. We feel very sad about it, but that's what it is now. The doctor is afraid of getting it. The patient is also afraid.
What it required, and I have been hearing some of the discussions from the medical association representatives and doctors here and there, what is required is practically that almost every health worker has to be fully kitted with PPE.
Yes.
And wear not just Ankara mask, and wear the 95% N95 face mask. Now, are we ready for that?
We are not. We are not at all. We are not ready. In fact, the truth is, some of us had to buy our own face masks to use when we get into the hospital.
Talking
setting.
About face masks, I mean, it is to say, for our viewers, it is to say that there are face masks and there are face masks. The kind of face masks that people who are in the clinical setting need to wear is not the kind of face mask that just anybody on the road should wear. You call it
N95.
N95 face mask. The kind of face mask we see those in the presidential task force wearing. Those are N95.
Yes, yes. Of course, they won't wear less.
But they are wasting it there, isn't it?
Well,
because they should be for doctors and medical other
they
health
will
workers.
like to maximally protect themselves, so they will wear that type.
So I'm saying it is those types, not the Ankara ones or the handkerchief ones. Even ordinary handkerchief can protect somebody a little. But for people in clinical setting, where people with all kinds of infections can
because
come.
You don't know who is who. You don't know who has it. You don't know who does not have it. You're just interacting with everybody. So actually, we depend on God a lot to protect us, because...
And God will indeed protect you all.
Amen.
I have seen on TV countries where, I think in the UK, they have made quite some progress with this telemedicine now. And for people who have computers, through Skype and Zoom and whatever, people are doing video consultation. Because the doctors are saying that it is important to see the face of the patient to get all the facts. You don't get all the facts just by hearing what the patient is saying.
No.
So somebody is complaining of some headache or some pain here and there. The way the person expresses it, the face, you can get more facts.
Oh, yes, you can. I mean, there's what we call the power of observation in medicine. Let me give an example. I was doing a ward round one day, And I saw a patient, a young girl, 21, with diabetes. She came with infection and very high blood sugars. But when I saw her, I noticed that she didn't give me a smile. So I said, "You are not smiling today." When I looked at her face, I saw some little bit of, I said, "You are not smiling today." Then she said, "Yes, I am vomiting and I have fever." So just from looking at the face, I knew something was wrong. So we use the power of observation a lot in medicine. In fact, when you're examining a patient, there's what we call inspection. So you look at that individual. This is an acutely ill-looking person. This is a chronically ill-looking person from what you can see. Even from the face, if somebody has difficulty in breathing, you can see from because the person will be using what we call the extra muscles for respiration. The nose will be flaring more than usual. You'll see it. Once you see that, you know that there is difficulty in breathing in this individual. So that's why even the issue of e-learning, medicine has some limitation as regards using virtual learning for medicine, because you have to see, you have to touch.
I mean, it's very important. I mean, talking about e-learning, we are in Terra here, we are involved in psychotrauma healing. And we say, how much of that can you do in training of people for that can you do at a distance? Because seeing somebody physically is so important in diagnosis of illnesses.
For example, somebody says, "I have stomach pain." There are so many organs in the abdomen. It can be a problem with the stomach. It can be that the liver is enlarged. It can be that the kidney is in trouble. It can be that the spleen has a problem. Until you touch and examine, you will not know which is which. That's why it's a bit difficult for medicine.
The progress they are making in telemedicine and video consulting is that actually they tell the patient to press here, press here, and the doctor is watching as the patient is pressing the various places. Do you feel pain? Press there. Do you feel pain? And so on. And it is reducing the number of people who present themselves at the hospitals. And I think we need a lot more of that.
The challenge we have in our own setting here is the issue of power, light. There has to be light.
Of course.
The issue, then how many people have access to computers?
Because this is not a mobile phone now. This has to be actual.
Yes, and then computer. How many people have access to internet? So these are good enough internet to show video. Not just So these are some of the challenges that we'll have to work at for us to be able to have effective telemedicine in Nigeria.
I think that some of the money being donated, whether locally or from international community, for COVID-19, rather than throwing the money out, say we are sharing money on the street, I think some of the money should be used to strengthen broadband system in hospitals, computer system in hospitals, and other areas, so that we can quickly graduate to this improved power situation. Because all that people are talking about doing things from home, if there is no power, what can you do from home? So what do you recommend for government and agencies and individuals who want to support that hospitals like your own, teaching hospitals like your own, what do you require now in order to be able to function optimally and continue to support people even with the present challenge of COVID-19?
Of course, power is number one. We need power because, I mean, the amount of money the hospital spends on diesel every month is enormous. Even my faculty, for example, the amount of money the university spends on diesel is about 450,000 a month just to supply my faculty light.
And it is not 24 hours?
It's not 24 hours. So power is number one. We need power. We need power. We need power. And then we need, of course, computers. We need to computerize everything, including the records and so on. We need electronic record system. We've started to do some work concerning the electronic record system, but we need to perfect it, and that requires money. And of course, internet, real solid internet. I mean, not the individual internet that we provide for ourselves right now. That's what is happening right now. Individuals provide, whatever you can to be able to do some work. And of course, we also need training, training of the healthcare professionals of all levels. so that we can all be on the same page. I think it's at that point that we can, you know, dream about talking of telemedicine. So we need a lot of support from individuals, from government, if only government can make health a priority. Health a priority.
Talking about making health a priority, we are told that the WHO recommendation for nations is 1 health worker per 400 people, right?
Yes.
And we seem to have 1 health worker per 4,000 people.
Well, I think more than 10 years ago, there was a conference of African heads of states in Abuja here, and it was on health. And they have a document called Abuja Declaration for Health by African heads of states. And the declaration, the commitment was that 15% of national budget should be for health.
15%.
And that was more than 10 years ago. Even war-torn African countries, they have gotten to 12%, 13%. But here we are, 3.5% or so.
So
we are
Abuja Declaration.
And the name of the document is Abuja Declaration for Health.
15%.
But that's where we are today. Yes.
No wonder the COVID-19 has taken us by storm, and we are like hands down overwhelmed.
So health is not a priority. That's a big issue. And also the health insurance scheme is still in the nursery stage. Less than 5% of Nigerians are under the cover of health insurance. And if that is the situation, what it means is that the average Nigerian is on his or her own. When it comes to serious health challenges, we are on our own. We run an out-of-pocket system. So what it means is if a Nigerian does not have cash in his hand, he or she cannot access health. That is the big, big problem. And so you find out that, for example, somebody has a chronic disease, kidney failure, for example. Kidney failure in Nigeria is a death sentence on the forehead of that individual. Because for that individual to have dialysis, for example, adequately, that will make the person well enough to be able to continue his normal routine, he needs an average of, and with the drugs, 3 dialysis plus the medications, that will come to, on the average, about 100,000 weekly. So it means this person needs 100,000 per week to survive. That is a very expensive life. How many Nigerians can cope with that? Or if a Nigerian has cancer, the anti-cancer drugs are so expensive. Even diabetes, drugs for diabetes are not cheap. And you find that, in fact, I have a man, the outreach I did in Kuje in December, there is a patient I inherited from there, a 60-year-old man, retired with no money, with diabetes and all the problems thereof. So now I supply him the testing. I had to give him his glucometer to be able to check. I supply him with the strips. I supply him with his drug. With this COVID, he called me and said, my medication, my insulin is finished. My glucophage is finished. I don't have the strips to measure my blood glucose. That's what he did. And I had to ask him to come and meet me in the hospital last week, and I, got him some of his drugs and all that. So it's a very big problem in Nigeria. We run an out-of-pocket system, and that is deadly to the health system.
It is indeed deadly, and I think it shouldn't just be the doctors that are crying about this, because this is our welfare. If the people have no guarantee of health care, and when people fall ill, there is no guarantee of treatment, even basic treatment, then that society is primitive. That society is not developed at all.
The 21-year-old with diabetes that we admitted came with a blood sugar of almost 400. And when immediately I talked of admission, the sister said, what did you say? Admission. Please, let's go home. Please, let's go home. Where is the money? And I had to say, okay, don't worry. We're going to admit on my name. I'll take care of the bill. We admitted that girl. They had not come to clinic for 1 year. And the reason was that there was no transport money.
And that's why he was getting what? Oh,
there
no
was
transport money.
There was no transport money to come. So for 1 year, she never came to clinic. When she came, an adult, a 21-year-old girl, she was weighing 30 kilograms. She lost so much weight, she was weighing 30. Her BMI was 13. Diabetes ate her up to that extent. And coming in that state, they said, what am I talking? Admission? Please. In fact, they were almost fighting me. And I had to say, okay, don't worry. We will admit, so we had to admit in my
A
unit.
21-year-old diabetes, is that what you call juvenile diabetes or what?
Yes, type 1 diabetes. We used to call it juvenile diabetes, but now we call it
type 1 diabetes.
Type 1 diabetes. She has had diabetes for about 3 or 4 years before then. So it's type 1 diabetes. And what she needs to survive is to give what is not there. What is not there is insulin. And that's what she needs. So she didn't come for 1 year that she had no transport money.
And the situation is just getting worse.
Yes. So that's the plight of the common Nigerian with any health challenge. That is not malaria. It's a serious problem.
Now, finally, to discuss about the doctors and nurses and pharmacists and all the, even cleaners in the hospital. We have been hearing from government about efforts to improve the circumstances of the doctors. What is happening? What is the management of the hospital doing or able to do now to protect the doctors so that we don't have here more and more medical workers and health workers going down with COVID-19? What is, apart from, I mean, the individual being careful, what is the hospital management doing? Let's say in your case, the teaching hospital, and hopefully other hospitals, what are they doing to protect their workers?
Well, in the teaching hospital, we have what we call the isolation center. Luckily, in our own situation, there was a new accident and emergency building that had not been furnished. Just
a block. Yeah.
A block that had not been furnished, just a new block, just completed in January or so. So when this came, that's where we turned to isolation center. And so of course, government in this situation helped us to quickly, smartly furnish the place, provide everything that is needed, brought in generators, even ventilators were brought in. But luckily, we have not had to use the ventilators for any of the COVID patients. So, and then there are complete PPE for the set of doctors that work directly there. They have the full PPE to wear before they attend to the patient. So that's one way of protecting the doctors. Then also we have hand sanitizers and antiseptics put in strategic places all over the hospital. In fact, if you want to enter the admin block, you wash your hand, with soap and water, antiseptics and all that before you get there. Anywhere, in every ward, if you have to enter, all that is there everywhere. And of course, we are also mandated to wear masks everywhere in the hospital.
So to go around in the hospital, you don't need the full PPE?
No, to go around the hospital, you don't need the full PPE. But where you are in the center where the patients are treated, you need the full PPE.
So the real challenge, therefore, is what we had discussed earlier about the doctor who sits down for consultation
and does not know
who this next person
actually,
and what.
That is the challenge. And that is why we have had to step down the routine clinics. Because you don't know who is who. The patient may choose not to give you the full history, and you are there just interacting with the patient. Blindly interacting with the patient.
Is that what is happening? This is happening in your hospital, but is that what is happening in what may be happening in other hospitals?
Yes, in fact, for example, in National Hospital, routine clinics are still running, but even the patients are not coming. For example, in my clinic there, for example, you find only 5 patients, 3 patients in a clinic that ordinarily will have been like 60 patients, 70 patients per clinic day. Now you find only 5, 8 coming. So even hospitals where routine clinics are still supposedly running, the patients are not coming.
Are the patients possibly getting well? I mean, that is to say, out of fear, they get well.
They are not getting, actually one of our areas of worry, of concern, is the fact that all these people with, diabetes, hypertension, heart disease, and so on, strokes, that are not coming.
Things may be getting bad.
Things may be happening at home that we don't know about. And since we don't have, telemedicine, we don't even know. So it may not be, we may find out that when we resume routine work, you find that some patients have died.
We need to beg people, our viewers, please encourage your sick relations who need to go for consultation, who need to go for clinic in hospitals, where the opportunities are still there, to please go. Protect themselves with face masks
Emergencies
and gloves
are
and so
open.
on.
Emergencies are open in every hospital.
Yeah.
And once there's an emergency, the person gets there, will be attended to.
Yeah. Well, don't keep people who are very sick at home. At least the person should be in touch with the doctors. And then there are medical workers, hospitals who never gave their numbers, their contacts. They expected people to come. This is the time to give some numbers to patients to call in order to be able to continue some kind of telemedicine. Once again, I want to thank all medical workers on behalf of Terra, on behalf of the other Nigerians, to thank all medical workers, all health workers who are on the front line of this COVID-19 fight. We are going to overcome by the grace of God.
Amen.
I have been speaking to Dr. Felicia Anumah, Professor of Endocrinology, and my younger sister, who is the Dean of the Faculty of Clinical Sciences at the University of Abuja. May the Lord bless your work and protect you and your family from any infections. And may your work and the work of your colleagues lead to healing and recovery of any Nigerian that goes down with COVID-19. Amen.